Welcome your hosts, Caddy Frank and Aaron Fitzgerald, as they lead discussions about substance use disorder and the journey to recovery. You're listening to Redefining Recovery, a recovery revolution.
Well, good day. A new day in front of us. Can't wait. So, welcome to Redefining Recovery, a recovery revolution. We are back again, and we love it. Mm-hmm. So, Miss Erin.
Yes, welcome, Caddy. How are you today?
I'm pretty darn good.
Good. Hello, Bill. You're back with us again.
Woo-woo!
I am. I didn't leave.
Yeah.
You didn't open the door, so I just stayed.
You're so funny.
Love that.
You. Before we get started, I'm going to say thanks again to the Patrick and Amy Butler Foundation, Otto Bremer Trust, the Sauer Family Foundation, the Hardenberg Foundation, as well as many other donors. We thank you very much, and we are happy to be here. And we're just going to start this right off with Caddy. What is right with you today?
Well, Miss Erin and Bill, I'm here with you, so that's just super fantastic. You know, last time we were here, I was going to go away for the weekend and see a friend of mine down in southern Minnesota, and that's always a great thing. Go down to Rochester, which, you know, we also know is a medical hub. But when I get to see my friend Terry, my life is just better. And
I love that.
She recently lost her mom, who was a beautiful human, Bev. And when I get to see people, even if they're in sorrow, we get to be friends. We get to just meet people where they're at. Yeah. So I am so grateful for that experience. So, Miss Erin, what's right with you today?
Oh, with me today? Well, it's been kind of a long week, and I am really excited for a weekend that is supposed to have really wonderful weather. So I can just be peaceful and really just be mindful this weekend. It's been a long week.
Oh, that sounds really wonderful.
Mm-hmm. Yeah. How about you, Bill?
I'm going to say what's right with me this month because early June and early July, we've got Juneteenth. We have all kinds of pride events. You go into the 4th of July, which is more veteran-centric again. And this is just a super fun time to be in the recovery business and to be getting out in celebrations and communities. And when we talk about addicts being stigmatized in general, then there's groups within addiction that are extra stigmatized. And going out and just trying to, kind of spread the message that peer support and harm reduction and community organizations are here.
I love that. It is a really great time of year to be in recovery. If you're new to recovery, check out some web pages. Check out TC Pride. They've got literally events, recovery events going on, other events as well. But check out our page and all over the place. There's so many recovery events going on right now because people think that when you're sober, when you're not having your substances, life isn't fun anymore. But that is not true.
So untrue.
Yeah.
I mean,
we were talking about mocktails just a minute ago, too. Those are so fun now.
Yeah.
I love them.
Yeah.
They make me feel like I'm fitting in.
Yeah.
I'll make mocktails with anything. I started using maple syrup in different things instead of other syrups and sweeteners.
You know what I love to do? I love to go someplace, a restaurant, or maybe one of the healthier places, and they have like the juice bars where you can to put some ice in a glass, and then you can do a little bit of this and a little bit of that and a little bit of this. I love just blending all that stuff together, and I feel so cool. I'm like, I'm healthy as well as I've got a taste that nobody's ever had.
Right.
So, it's just like, I get to blend my own world, and it's sort of fun. So
I love it.
Yes.
My fifth soberversary is on July 4th, and everyone says, oh, because it's your Independence Day. I said, well, not exactly. I went into treatment on July 2nd, and you go into the medical wing, especially as an alcoholic, to make sure you're totally detoxed, you're not going to have seizures or anything. And they give you medications to prevent that, one being Librium very commonly. And I think I was more altered on Librium than I've ever been on alcohol. So between July 2nd and 4th, when I moved into the men's wing, I can't argue that I was sober at all. So the 4th is just the first day I was in treatment that I could think.
Right. Wow. Well, we are welcoming Bill back for a second show because he has a continuing journey that he sort of alluded to about some real health crises that were unfolding, and his family was very supportive, and he was kind of getting on the let's see how I can get better train without much argument. But, you come into this with 30 some years of using substances, and getting on that train is really, really hard because we are, how do we deal with the pain or the physical ailments or the psychological pain that we're dealing with, the trauma? How do we manage that if we think we're going to not have our friend, alcohol or drugs anymore? And it's like, what does that look like? And it's terrifying in most cases. Bill was kind of ready.
Yeah. Your story is interesting to me, Bill, because I feel like, and I'll let you use your own words, you actually felt maybe a little more stigma after recovery or in your journey to now than really before.
Yeah, so, you
don't have to start there.
Well,
but
I was just say there's two significant events in treatment in general that happened for me. One was just my own awareness increasing, but of course what I learned in 7 weeks there was just the barest hair's width of knowledge in recovery. The other was that my wife and daughter did a weekend family program about addiction, and that was pretty transformative because that takes down the question of why don't you just stop?
Yes.
Or why didn't you see this earlier? And it talked to them more about the stigmas, the mental health, the hardwiring, the genetics. What does this actually look like from a medical perspective? And that made them much more personally, I think, internally compassionate. Like they were still really mad.
Yeah.
Desire, they've earned it. So when I came out, I was still very sick, and I don't think anybody gave me a chance to not drink or to even survive. And I went back to the Upper Peninsula of Michigan, pretty remote, not a lot of services up there. I was a college professor in a little state university, and my students all knew I was sick. When I left treatment, they said, sorry, there's no treatment up there, which there wasn't. But I found a counselor, I can't even remember how, but she worked for a Native American health clinic.
Wow.
And she took an interest in me, and I met with her, and she got me involved with some massage therapy, and there were some goofy little AA meetings. And I was able, and also post-treatment, I had elected to be on what they called a Sober Link program. So I had like a little mini breathalyzer that I blow into 3 times a day in a certain window, which for me was great accountability. Like when we get to the point of going into surgery, I had a death grip on this thing, and I wasn't gonna. It'd been turned off for like 2 weeks, and I know, like I gotta blow into this at 5 o'clock, and the doctors are all mad, and my wife's like, just let him do it.
Yeah.
So I had a lot of pieces in place, and it's probably kind of a miracle that I did make it through that period, because again, the trigger in November that year was another major health catastrophe that put me on the speed train to getting physically fixed. But the stigma, no one, my students all knew, the other faculty knew things weren't right, but no one asked. I had, there was one administrative member who just walked up to me in the hall one day and goes, your skin looks horrible today.
Oh.
I said, oh.
Thanks.
And I just looked and I said, that's funny. It looks better than it did yesterday to me. What can you say to that?
Yeah, how do you respond?
He's not trying to ask me anything productive. He doesn't want to know what's wrong, obviously. And during this period of time, I was actually intervening with students who had substance use disorder.
Wow.
I was walking students over to the counseling center. I was giving them, resources provided by the university, knowing I was right on the front end of my recovery. And I was kind of doing that on autopilot to be the professor I was supposed to be and not really thinking it through. I mean, I'm glad I did.
Yeah.
But I still had so many blind spots, but I stayed sober. That's what was important. But the health thing, a lot of stigma there. And, again, anyone can have addiction. So, what's this college professor?
Yeah,
How did he get himself into this? I'm like, well, same way anybody does, really.
Yeah. Life.
Yeah, just
Life.
stuff.
Yeah. Wow. Again, there's just so much unfolding in this conversation. And I say, if we think that we know somebody who's struggling, we have to talk about it, but talk about it with love. It's been our consistent message since we started this program not that long ago. If somebody seems like they're hurting, they probably are. And if they're using a substance that is, you potentially think, or point blank it's doing something to them, say something. out of love, not out of judgment, not out of intervention. So we're going to take our first break, and when we come back, we're going to continue on this journey with Bill, with his story, and we thank you for listening to Redefining Recovery, a Recovery Revolution.
Welcome back to Redefining Recovery, a Recovery Revolution. I'm Erin Fitzgerald. I've got Caddy Frink across the table from me, and we are joined by Bill Houston. Bill, you've been telling us an incredible story, which is your journey to recovery. And so it sounds like we're getting to a piece where you may or may not have gotten a liver transplant, yeah?
I could show you the scar.
Excellent.
But, this is a family show. If you remember the last time we talked about, I said that I went and saw a doctor, and he said, yep, it's a liver issue, and come back in 6 months. And I didn't realize at the time that's kind of the bar. And he knew I was in treatment.
Okay.
So there was going to be some progression no matter what. So, in that 6 month time period, I would go back and they'd figure out where I was at, because sobriety is important if you're going to get an organ. So I was still teaching at the university, kind of cobbling together my recovery, kind of on my own, calling a lot of friends who weren't even addicts around the world, really, friends of mine, just to talk, trying to be open, and my family was supporting me. And we get into November, and again, catastrophic health issue. I had fallen again and had a very bloodied up arm, and went to the ER, and they were like, your blood counts are so wacky, out of control. And they started doing transfusions and infusions, and again, no trauma level care on the Upper Peninsula. So they put me in an ambulance and drove me 11 hours to the city, to Minneapolis. And, went into with my hepatologist, the liver doctor, and went into the transplant screening program. So this is about, maybe 5+ months, not quite at that 6 month level. And I spent a week in the hospital going through ridiculous amounts of screening. And part of that screening is the analysis of your sobriety. So, okay, Bill's got this much treatment. He was in the SoberLink breathalyzer thing. He's, shown this recovery counseling, blah, blah, blah. He's tested negative the whole time. And so the last piece of that puzzle really is, can he survive the surgery?
Wow.
So turns out everything's great. My heart's great. My lungs are great. My kidneys were great. Who knew? Because those go at the same time commonly.
Sure.
It was just the liver. And the second part is, what's your support network look like? Because if you come out the back end of this, whether you have substance use disorder or whether you're just not a disciplined patient and you do stupid things that will hurt yourself, is important. And my wife and daughter were the advocates extraordinaire. Another part of my story, especially for people with SUDs, you have to self-advocate and have people advocate for you in medicine.
Absolutely.
Medical people can be very detached from each other. That's not a character flaw. It's just how the system is. And you have to be able to advocate. And sometimes it requires you to be politically correct. Sometimes you have to be angry. I never knew wife and daughter who was good or bad cop. I think they were both bad cop a lot. So I went through that week. They said, okay, go back to Michigan, and within the next few days we'll have you put on the list. And we went up. We got home, and the first night I slept in my own bed. I spiked a fever of 102. Went back to another non-trauma ER, ended up with a life flight back to Minneapolis.
Wow.
Land in Minneapolis. I don't, off the top of my head, remember the day of the week, but we can talk in days now. So I land on one day. I'm listed the next day, and the next day I had a liver match.
Wow.
That requires the blood type match. I mean, there's a lot of things that go into it, but I was also once you're accepted, it doesn't matter why you're there. You don't get, they can't take you down because you're an alcoholic. So I was at the top of the list because I had imminent mortality. And, my doctor told me I had a month, and he's telling my wife and daughter I had a week, to be nice, I guess. So I had the transplant about 48 hours after landing in Minneapolis, and then begins the recovery part of it. And another medical piece of it, during that week, so I had what they call hepatic encephalopathy, which is when your liver doesn't work and your body kind of floods with ammonia, and the ammonia short circuits the brain fluids. And you're like a 5-year-old with Alzheimer's, basically. You just can't do anything. And my wife said, the only thing he's been able to focus on is recovery. Let's get an alcohol and drug counselor in here he can talk to at least, because they kept sending me chaplains and, here's our ambassador, and it was an old gentleman with a drooling chihuahua and, just not my thing. They couldn't bring me an LADC because it was in a totally different unit, and they couldn't figure out how to cross-bill it into transplant.
Oh,
Wow.
Louise.
So, again, when we talk about recovery-oriented systems of care, they don't really exist right now. So just another little glitch in the system. I mean, at that point, it didn't matter that much, but it seems silly. And that's something...
You would think
Right.
that with the cause of many of liver transplantees, that there would be somebody with
Some kind of a crossover.
some
So
sort of...
now, a lot of these transplant programs do have a dedicated LADC, but, those are the people that basically do the final thumbs up or thumbs down. So someone comes in, hey, I'm 3 months sober. I haven't made 6 months. And the LADC is going to be the one that goes, well, based on my evaluation, this person's not going to stop, or the doctor might just say they won't survive surgery. So that's not what most LADCs are in it for, to essentially be holding the guillotine rope.
No.
So it's when you get into this dire state, of course, there's a tremendous amount of stigma about why you're there, and I feel horrible for people that have genetic liver diseases because someone says, "Oh, you got a liver transplant, so you were a drinker, huh?"
Yeah, it's automatically
No,
assumed.
I've got 7 family members that had the same disease. It's
They have to explain.
so the outcome after my transplant, it was a good 10 hours. I was told I got 17 units of blood because I don't think I had a platelet to spare. But physically, I was in great shape. My kidneys recovered in a few days because they take a little bit of a hit. I didn't have any rejection episodes. I didn't have any major infections or anything. But I had this cognitive decline. So I mentioned the encephalopathy that makes you useless. They say, well, once we replace your liver and it processes ammonia, you're fine. Not so much. And just from my peers that I talk to, I think about 1 in 5 of us or so, maybe 1 in 6, get a really long-term cognitive decline. And again, I couldn't do any self-care. I couldn't do anything. So my daughter Megan was my caregiver for the first year of that while my wife was still working in Michigan. And
Wow.
and this is when November 2019 is a transplant. March is when COVID hits. So poor Megan, living at home living in an apartment in Minneapolis just with her useless dad and a couple cats, and she can't even go out and get a cappuccino.
Wow.
She is just stranded. So, kudos to her for taking that hit for the team. But it took me the better part of 2 years to come back to any semblance of full thought. And during that time, I couldn't do any aggressive therapy because I couldn't think well enough to do therapy. Like, I could literally not follow directions. I had no balance. I was working with physical therapists who were scared to let me out of chairs. I did one little test a year later in a little wooden car. I had to show that I was going to practice driving, and I fell into the car and I pulled the steering wheel off, and it was just a mess.
Goodness.
That sounds frightening.
So it's terrifying because everyone around me is going, what if he never gets better?
Yeah.
What if he's actually really short-circuited his brain? Because that happens.
Wow.
You hear wet brain, things like that. There can be irreversible damage. When I started kind of crawling back, it was a very slow process, and maybe about a year plus into the recovery, they said, well, let's send him to a neuropsychologist and do testing and kind of see. And I went through, over a year's time or more, I went through 3 fairly comprehensive neuropsych testings. You build things with blocks and you answer questions, you memorize stuff. And this is when I had a therapist say, you really sound like you have ADHD. Wow. And they said, well, I don't know that we can diagnose that in an adult without a child's history. But I gave him kind of my thoughts at this point. And he said, maybe. So I went through all this neuropsych stuff. And long story short, at the back end of it, the guy was like, you definitely have some short-term memory issues. Now, we don't know if that's surgical recovery or if that can be an ADHD thing. The other thing he said is you're of quite high IQ. There's a correlation in a lot of places where high IQ and addiction are similar. And this goes back to the question of my wife, you were self-medicating. So those pieces fit together. And then, of course, in my sobriety and once my brain started working, I'm just everywhere all day, all over the place, which is
That's
fine.
why our conversations are so fun.
I know. Erin doesn't say much on the phone to me. She just kind of listens and then weighs in and says, now, what did you call for? What are we trying to solve? So this progression, and during this progression, since I couldn't do much, was my chance to do my internal recovery.
Wow.
And so I was diligently going to AA meetings. They were terrified of me because I was a mess, but they came to realize I was harmless. And you know, credit
This has a lot to say.
yeah, credit to AA. I needed that structure because I couldn't think on my own intellectual binges, and it really gave me things to focus on. And since then, and now that I'm in a career dealing with harm reduction and standard to alternative methods of recovery and things of that nature, I've kind of branched away from that big book thought and things, but it doesn't mean that that's not a great foundation. And so
Say the
everything
same
I've
thing.
done since, and I had to go back to work in bits and pieces. I was working part-time as a manager in a sober house. That was my first job, if you will, in recovery. That's a hard job.
That's what you were doing when we met, yeah?
Yeah, that's a hard job in a
Yep.
house with 25 guys, all on the edge.
All needing
the time.
support.
All over the place.
They need support, yeah.
So, but that kind of hooked me. That you know what really got me jazzed in this whole thing was the stigma part, because I've been a scientist my whole life and I've been an educator my whole life, and I did a lot of work for advocacy in using science in the public interest. So, you know, today we have all the global warming crap. This is before that happened. So it was like, what do people need to know about the earth sciences for their own well-being? Where does oil and gas come from? Where do minerals come from? What are you building your house on? So I always had this correcting misinformation piece to my background, and I fell back into it. I went, well, this is brilliant, because misinformation and stigma are the whole problem here too. And the company I work for very much leverages evidence-based science in what we
Right.
do. So we can talk in general terms a lot about harm reduction and, you know, hugs and being peer support. But the basis for the medications
Yep.
is evidence-based science, statistics, lab studies. And those even go into different kinds of recovery. So you can look at statistics of what does inpatient do? What does outpatient do? What do counselors do? What happens if you do all of them? So that was the message. I mean, I love the peer support of my peeps, if you will. But I really like getting out in the public climate and doing outreach and advocacy and saying, you lose nothing by saving all of us. We have mothers and brothers and husbands, and you know, we're people.
Yeah.
And we all have different traumas, and some of us will get over them and some won't. That's, you know, the unfortunate truth. But I see too much evil on the internet about the stigmas against addicts. I was in a group meeting and we were talking about people, different kinds of death, basically suicide or overdose and things. And a woman made a casual comment that, well, you know, when some people die, it might not be that tragic. And someone said, well, like what? And she said, well, like pedophiles, murderers, and addicts. And I looked at the group facilitator, and she just kind of gave me a hand signal, like, don't say anything, because I was ready to go across the table.
Right.
And she's a lovely lady. She didn't mean anything harmful, but that's the mindset.
Right.
Yeah. Yep.
And in the sober house, I'm like, these are guys who desperately wanted to see their children,
Yes.
and the legal system was keeping out. They're guys who had returned to use dozens of times and made good faith efforts every time. They were people who had lost careers and families and couldn't go back, like, you know, living careers.
Yeah.
No reason they shouldn't be able to go back, but they couldn't. So that became part of this thing. And then also on top of this, because of the medical story, is the stigma in medicine trying to work on these recovery-oriented systems of care. Like, how do we identify the people who are going to have – there are interventions, medical interventions for liver and kidney problems well out. They might not prevent a later transplant, but they might delay it, which improves the system, actually, of the distribution system. How do we get primary care physicians or people more involved? This is where I think the peer support's really good. You get someone who's maybe arguably a year out from being in a real problem, and you say, go to this drug counselor. They go, oh, no way. I don't want to be told I have a problem. It's a lot different. You say, hey, I got this peer gal, Erin. We don't really know what she does. She runs around.
I don't either.
Yeah, she's got a crazy little cute boy, and she just hangs out and talks to people. Go talk to her.
Because you got something in common. It's
Yeah.
going to sound different. It's going to look different, but you got something in common.
Can relate with you, yeah.
Yeah.
Can I ask about that stigma?
Of the medical piece?
Yeah.
So I went in a couple years ago. I get quarterly blood tests because that's where rejection will show up if it happens. And they're all usually fine. I go in, I'm getting my blood drawn. And very nice there. She looks at me and she goes, "Oh, I noticed that we're doing a hepatic panel, a liver panel." And what was that for? And, I don't worry about HIPAA in these conversations because it's good to talk to people, especially medical. I said, "Oh, I had a liver transplant." She goes, "Oh, you feel good?" I said, "Yeah." She goes, "That's great." And she goes, "I'm so glad you got one." I said, "Yeah, it was really a miracle that the match came so quick." She said, "You're lucky you grabbed it because, some people get organs that probably shouldn't get them." And I knew where this was going. And I said, and there was another nurse I could see out of the corner of my eye kind of listening in because she's bored and just trying to figure things out. And I said, "Really? Like who?" And she's like, "Oh, people that," she goes, "people that don't know how to treat their organs." What does that mean?
Yeah.
It's like treating, like putting oil on your furniture. How do you treat your organs? And I said, "Oh," I said, "Yeah, I actually did get kind of lucky because mine was from alcoholic cirrhosis." She froze.
Good.
Hardly said another word to me. The lady who was listening ran around the corner and hid. And I kept engaging her in a friendly manner, and I just loosely explained to her. I said, "Oh yeah, I've had a long career drinking, and done a lot of good things, and still want to do good things, and I'm really blessed, and I have a good support network." And she was very nice and very terrified.
Yeah.
And I know she meant no harm.
Uh-huh.
And I get it when you say, and there's a weird survivor's guilt for people that have organ transplants. We know we're not responsible for the deceased donor's demise. I mean, it had nothing to do with it. I don't even know how my donor died, but it was in another state, and I was told it was a non-traumatic death. That's all I know. But there's this guilt of, why did I get it?
Yeah.
Like, who didn't get this one? What if that person didn't survive? What if? And I think that's where part of these medical circles get in. Like, we all want these precious organs to go to people that are going to put them to good use. That's totally understandable.
Yep.
And being a quote-unquote addict doesn't, to a lot of people, say it's good use.
Yeah, it doesn't fit the model that we would like to see happen.
But I'll just quickly say another comment about that. Plus or minus, I don't have the exact numbers with me, but there is, in my quarterly blood tests, about once a year, there's a PEth test, which is to test for long-term alcoholism. Like it'll, for 3 or 4 weeks after you drink, it's something they can test in your blood. It's not legally reliable, but it's a good indicator. And about 20% of liver and kidney recipients test positive for alcohol within the first year, and about 40% at year 5. So going back to this whole recovery business, we're pushing people through the front end to get them qualified for the liver. So they'll say, "Hey, go to this virtual outpatient thing, and then talk to a counselor. And if you make it 6 months, we'll give you a liver." That's sobriety. That's not recovery.
Exactly.
Right.
You got to make sure they're ready mentally.
Yeah.
And then the transplant teams will tell you, we have no sway over anybody once we kick them out the door with a new organ. We don't, we can call and follow up.
But there's really no
There's
real
no
method,
real follow-up.
like there's
Yeah.
really no process program to help them on that journey. Wow.
And I can promise you, someone with a gifted organ is guilty as all heck for using a drug after they get an organ. I mean, this isn't something that they go, "Hey, I'm alive, yay me."
Right.
It's because you're an addict. You have substance use disorder. It's still, I never say to anybody, "I was an alcoholic." I say, "I am an alcoholic. I'm in long-term recovery." Fingers crossed, do everything right, stay in long-term recovery. But now when I go out in public and I talk about this whole thing, and people are a little shocked that I talk about it. And, I'll show anyone my scar. I don't care. Someone did tell me it's a lot scarier looking than a C-section scar and about twice as long. So I don't know if that's anything I can use to say how cool I am. But
Scars are cool.
I'll get, maybe at the end we'll talk about this a little bit about telling your story. If you are willing to do it, if you have the constitution, you get your head around it, telling your story is probably the biggest thing you can do to armor your own long-term recovery, because you can't be stigmatized if you just tell people everything.
Right.
Yep.
It's really hard to feel shame when you go, "I don't care if you like it.
Yeah. This is the truth. This is my
is my
truth.
This is the way it is. It's my and you can nitpick it if you want, but I've got the scars to show it."
Right.
If you're not willing, say, to come on the radio and tell your story, that's fine. That's not everybody's piece, but tell your story to yourself. Tell it to a close friend. tell it in an AA meeting, an NA meeting, tell it at church, whatever, you know. Learn to tell your story even in your own head so you can look at the stigmas and you can look at the shame that's put on you and go, well, that makes no sense. I'm not a rotten person. You know, I'll tell you the going cost of a transplant, just the surgery, I think is about somewhere in the vicinity of about $800,000 just for the surgery. And I'm, you know, a couple $1 million man by virtue of the subsequent care. So we should value the people that make it.
Right.
Whether you get a transplant or not. Let's use these people and the experience I found, and corporate entities are doing this now for people that are in recovery who are their employees. They want them to talk to the other employees.
Yeah.
Like, hey, when you're gossiping in the mailroom about how you didn't get a company T-shirt, well, that guy got a kidney. Get some perspective, you know. But use the strife we've been through in recovery to empower other people, not just people with substance use disorder, but everybody.
Yeah. Well, there's so many people who are affected by the disease of addiction and substance use disorder, the family members, the community members, the work people. I mean, and we all kind of know somebody who struggled somewhere along the line, but we're, like you had said, Aaron, we're afraid, or we're unsure, or should we or shouldn't we? You know, it's going to make them uncomfortable. It's like, let's get uncomfortable.
Yeah, absolutely get uncomfortable and see it. Yesterday we were just talking about this. A lady in class had said, how do I bring this up to somebody? And you can just say, you know what? I'm worried about you, or I care about you. This is what I see. And it's that simple.
Yeah. It's acknowledging the fact that there's been a change in someone's behavior or somebody's whatever, because we all see it.
Yes.
And
I love you.
I love you. Yeah.
Or care.
Wrap people in hugs.
Right. Yeah.
You've got to be frank with your language. I just finished a suicide intervention class, and part of the methodology is bring up the word suicide early in the discussion. Don't mask it.
Yep.
That's what it is. Same thing in recovery. So I saw on a Facebook page, someone said, I'm thinking of unaliving myself. And I fired a note back and I said, if you're having a suicidal ideation, call 988. So call it what it is, provide a resource.
Right.
The resource could be yourself. It could be, I'm worried about you. I don't know how to deal with this. Let me suggest something, or let me try to help you, or, but be frank, but don't be too blunt either, because you need the person to be on their own journey. That's part of my story is, I had to find my recovery. There was no way I could be forced into it. I mean, thank God I had people that cared about me, that put me in treatment. Thank God that I had doctors who believed in me, and that I have a donor and a family of the donor out there somewhere that signed off on it. But you've got to let a person recover on their own. And if they're stigmatized, they have nowhere to go.
Right.
They don't know where to go. They don't know who to ask. They're not going to self-admit. And I, unfortunately, now being in recovery and all, and even in just going to AA meetings or being out in the public, I'm meeting people all the time who have the families of people who have died or who will die because of liver or kidney disease from alcoholism. And it's amazing now that I'm in that community how many there are.
Wow.
Because they get in that dire place. And so, interesting saga, my wife, when she first talked to the liver doctor, the hepatologist, she was kind of running through a zillion questions with him, and he was very silent. And he's a very personal guy. And she's like, what, did I insult you? He goes, no, I'm just not used to family members still being involved at this stage.
Wow.
And he was saying it like this is a wonderful thing, but he was saying the reality is a lot of my patients are not going to make it because they come in dire need with no support network, no knowledge, no recovery, and all they can do is look at them and say, and one guy I knew from support groups, the doctor had to look at him one day and say, we've taken you off the list. You really should consider hospice care. And he died about 3 months later.
Wow.
So getting to people early and often, being compassionate and kind, not giving up if they're resistant. Don't get mad. Don't yell at them. Just go back again. Hey, just another check-in. Kind of, what I said before.
Yeah. Still here.
Still here.
Yeah. So, beautiful point to get to, and that is, it's all about acknowledging, caring, being pointed without being unkind, recognizing that people struggle in so many different ways. And if we just stay present, it may take a while, but it can make a difference to somebody, because people have been told what to do, when to do, how to do it all the time if they really have struggled. And then all of a sudden we say, I'm still here. I'm still here. So we are going to take our last break and conclude this incredible conversation with Bill. So thank you for listening to Redefining Recovery, a Recovery Revolution. We will be back momentarily.
There's no song, and this house needs love in it, 'cause without it there's no home. And this one...
Welcome back to Redefining Recovery, a Recovery Revolution. Bill, you were with us last week, and you've been with us today, and we've been having some really great conversations, and thank you for sharing your story. What would you like to share with us to kind of close out your story?
Well, I guess a little soapbox or two maybe in proud company, because what we all do is talk like this every day between ourselves, to our colleagues, to other people. And it's great to have a chance to get out on the airwaves and talk to the public. And I love doing public outreach, and I'm pretty fearless about it. If people want to walk, I've had some interesting racial epithets thrown, because we're on radio, so you can't see the very pale skin and the ponytail, and Birkenstocks and socks and other things that make me a little weird. But I think it's so important to talk to the public. I mean, we are here to, quote unquote, fix those with substance use disorder. We spend a lot of time as peer specialists. I spend a lot of time in my clinic helping people try to get over their addictions on their terms. But we need to talk to the families. We need to talk to the municipalities. We need to talk to the government. If you ever have a question, I get this all the time, like, I think syringe exchanges are just legalized drugs, blah, blah, blah. Or, why are you giving opioids to people to get over opioids? We don't do things arbitrarily.
Right. There's an intention here.
Yeah, and no matter how progressive you are, we're not suggesting that the broad-scale legalization of drugs will solve anything. This is about harm reduction and treatment. So harm reduction is a series of practices to help people get over their substance use disorder, and not overnight. And it acknowledges people will make mistakes along the way. It acknowledges that the first couple efforts might not work for all different reasons, and we need to track what doesn't work and then try things that do work. Right. So, talk to people, call Minnesota Recovery, call Community Medical Services, there's a lot of nonprofits out there called recovery community organizations, which are nonprofits that are specifically targeting different aspects of recovery. So they might own sober houses, they might do outreach, they might do professional training, all kinds of different things. Some do advocacy. Some just hand out Narcan. So ask questions, get people in your community, ask the local library for a room to have a neighborhood of people over, or the YMCA. I'll show up anytime. And ask, because the only way you get around misinformation and stigma is with information. And if you ask me a question I can't answer, I'll find the answer. Because I also, as a scientist, I firmly believe in the basis of what we do. So I'm not just blowing smoke and saying, oh, yeah, well, if you just reduce this, you'll be fine. I'm still looking at an end goal to make people healthier and increase their well-being. And we have tremendous resources for that in Minnesota. We are lucky to be in a state where a significant amount of funding currently is going into harm reduction, and where the certified peer recovery specialist and its partner, certified peer support specialist, which is toward the mental health side rather than recovery, I've got both certifications, are supported in the workforce. And there's a longer term probably plan for that needs to happen to really cement the CPRS into these recovery-oriented systems of care. So instead of always having acute intervention, hey, I'm drunk, I fell down, I broke my head open, you go to the ER, they stitch you up, they yell at you, the police cite you for disorderly conduct, and they send you home.
Literally how it is.
Oh, but look, on the arrest report, it suggests you should see a counselor. Get people talking. And the community plays a role in this peer support. If you can get people pointed toward resources sooner than later, then we don't have the big drains on the medical system. On the legal system. If the ER is clogged up with acute trauma from addiction, if the legal system is all plugged up with people who are desperately trying to get housing or get their kids back or something, but they have SUD, and that's the impediment.
That's the nut.
Yeah. So we need the community desperately, and we need to be able to have very honest and hard conversations in the community. And to do that, we have to be colorblind. We have to be recognizing all different faiths. We can't stereotype based on age or hair color or gender, because substance use disorder affects everyone. It does not see color. It does not see income. I don't do this often, but when I've had some frank talks about what my level of education is and what my economics have been over my life, and people are always like amazed, like, well, you've had the means to deal with this for 35 years. I said, but I didn't want to, because I was just having fun. It doesn't matter how much education you have or how much money you have. It's addiction. It's a disease.
Yeah. I think that's one of the key components to all of this, and that is addiction doesn't care who you are. It doesn't matter how much money you have, what neighborhood you belong to or don't belong to, for all intents and purposes. We know a lot of people living without homes are struggling with substance use disorder, but they might have had a home before, but their substance use got in the way. But nobody was there to interrupt that situation and say, hey, come over here, let's talk about this. You got a problem. We don't know if we got the solution, but we're willing to have the conversation with you. It's okay.
Yes, I love it.
You know, Erin and I later today, we're going to the place in North Minneapolis that we want to, what is it called again, darling?
It's Minnesota Overdose Awareness.
Yeah, we're going to, it's on 39th and Fremont North. And again, to your point, Bill, we need to have places where people can go to find resources, to find kind humans that you had in your family that could say, hey, go to treatment. And you're like, I'm so tired, I think I will. But there's a lot of people that say, no, freak it away.
Yeah.
I don't want this. So what's the next? Like you said, harm reduction. It's so big. It's so honorable. It's so much there. And if people think having a syringe exchange site or other organizations in their community and say, well, I'm not going to have it in my neighborhood. I'm like, it's in your neighborhood anyway. So why not have a place where people can get some good stuff to help themselves and maybe get on the road to recovery? Because to quote the video that we talk about in harm reduction, you can't save a dead addict.
True.
And that addict might be your friend, your brother, your sister, your aunt, your uncle, your cousin, your somebody. We can't save dead people, but what we can do is we can intervene, we can talk, we can care.
And don't ever forget that taking away the substance is not the end of it, right? Finding recovery is lifelong because we're learning how to cope with things. We're learning new behaviors forever and ever.
Well, and arguing what borders the substance is coming over, or is it internally made, that's a law enforcement issue. That doesn't help us at the community level. And when I, talking about opioid disorder specifically, because that's what my clinic deals with, I don't know what the proportion is, but I think, pretty much for every person that's on the street using fentanyl, unhoused, having horrible problems, there's someone addicted to prescription Percocet in the suburbs. And there's a statistic, Caddy, you might know this better than I, but isn't it like 76 or 70% of opioid overdose deaths they die alone, and
88%.
about
88%.
and then a significant percentage of them die in a residence or dwelling.
60%.
So we have a lot of people come in off the street for help because they know we're there. And as groups, they'll come in and refer their friends. The people to touch are the people living rooms, doing it with prescription. And you know what? If you get really hooked on prescriptions, you're going to go find other sources when those dry up.
Right.
Yep.
So again, you got to be willing to talk to people, talk to your people.
If you see something going on with something, say something. And I mean, it's like at the airports. If you see something, say something. Well, same thing works with substance use disorder. Somebody who's struggling with drug addiction or alcohol. If you see something, say something.
Just real quick, want to put in before we run out of time. All my love to Chris and Megan. I wouldn't be here without them, obviously. We just had our 26th wedding anniversary.
Congratulations.
Which is good fun. And I just so much love and gratitude for the family of my donor. I don't know who they are. I don't know if they'll ever hear this, but these are people that lost a person right around the holidays because that's when my transplant was. And I think about him every day. I think every day about doing right by him and making him proud.
And you have.
Yeah.
You have. Literally just brought tears to my eyes in the
grateful.
sense that gratefulness is evident to us in our recovery community. So thank you.
And grateful to you, too, for being in the clown car with me.
So
Oh.
grateful to squeeze you in.
Yeah,
I know I owe you donuts.
Well, no donuts for me. But you can be a part of our family anytime, as you are part of our family anytime, because we can have some great conversations. So join us in supporting our mission at Minnesota Recovery Connection. You could be a monthly donor. You can be a annual donor. You can volunteer at Minnesota Recovery Connection. We do not survive without our volunteers. So feel free to reach out to us at minnesotarecovery.org. Click the donate or the volunteer button. Bill, thank you so much for being here. I
It's a
greatly
pleasure.
appreciate you.
Good fun. Thank
Love
you.
you.
Thank you both. Love you both.
Thank you.
And
seem that
there we
long.
go.
Double
No,
fisted.
no, it's yeah.
Is that what you're looking for?
Look at
Oh,
that. 2 minutes
Perfect,
early.
yeah.
You're welcome.
All right, I
we're-
got to get you guys moving a little bit here. So I just got to get you guys moving a little
Yeah,
bit. So we
we're
have
on
our next
the
show
clock.
coming in. Yep.
Get out.
Sorry there, guys. Yeah.
Here, in other words.